Welcome, everybody. I want to welcome everybody to the Callahan lecture, and I'm going to set up. Okay, I'm just going to. As they say, real bioethicists have trouble with technology. Well, I want to welcome everybody to this wonderful event. It's going to be in two parts. Our president, by the way, I'm Joe Finns. I'm chair of the board of trustees of the Hastings Center. I'm honored to do that. And we're going to hear from President Vardit Ravitsky, who's going to unveil our strategic plan, which has been in the works for about a year, and we're very proud of it. And following that, we're going to have the Callahan lecture with Joshua Boger and Gina Kolata, who has somebody I can't forget, obviously. And I think it's the perfect combination for the Callahan lecture. Dan was a philosopher who wrote like a journalist. So Joshua was a philosophy major and a chemistry major at Wesleyan. And Gina has been probably one of the most wonderful medical journalists and science writers that we've had in our generation. So I think Dan would be thrilled that the two of you will be in conversation in such a public way. And I'm really gratified that you're both willing to do this. So for now, I'm going to turn it over to Vardit to talk about our strategic plan. Vardit.
Thank you so much, Joe. This was set up for my height, so. Thank you, everybody. We're so excited that you joined us today. Welcome to old friends and to new friends. I'm very excited to reveal the Hastings Center's new strategic plan for the coming 5 years. It is the result of many months of consultations with Hastings staff, board, advisory council. Most of you are here with us today, with our colleagues nationally and internationally, with our fellows, friends, and supporters. And it was guided by a wonderful task force that accompanied the process for months. I want to thank each of them, and their names are on the screen. Some of them are overseas. I just want them to know that they're being acknowledged and thanked. The process of thinking about the future of Hastings Center, and in a way the future of bioethics, culminated in the approval of the plan by our board in December 2024, before the current changes in our political landscape took effect. And as we all know, concepts that were seen at the time as an obvious mission of bioethics, being inclusive, promoting equity, addressing social determinants of health, have become volatile. In 3 months, the landscape around us shifted in unprecedented ways, and today, presenting these strategic priorities to you seems almost like a risky act of moral courage. I also feel the need to acknowledge the raw emotions of this time. Colleagues and friends have lost their jobs. Consequently, our field has lost some of its fierce leaders. Students are losing their funding and the opportunities to become the next generation of bioethicists and scientists. Centers and programs are under risk of disappearing. Academic journals are being threatened. Many feel afraid and even silenced. I want to acknowledge this reality before I present a plan that was conceived in a spirit of optimism, energy, and excitement for a better future for all. So in my short remarks, I plan to first speak about some of our priorities and plans for the coming years. And then I want to contextualize our plan within what is happening in the world around us right now. So a few words about the plan. First, we have a new name. We're not letting go of the Hastings brand, of course, but we're adding bioethics to clarify our mission. We're not defining what bioethics means. We're leaving it open-ended to leave the scope of our mission broad. Someone once told me, and Joe likes to cite that whatever the Hastings Center says is bioethics. That's a heavy and awesome responsibility that we take very seriously. And so our vision for the field is broad and inclusive. It's not bedside only. It's not research ethics only. It's the impact of climate, of emerging technologies, of aging societies, even of urban planning. It's a very broad view of all the ethical and social issues that surround health and well-being. Second, we will remain independent and nonpartisan, but we will lean further into organizational partnerships and collaborations. We're small. We famously punch above our weight. Everybody always tells us that. But we need the support of the community to succeed and to have societal impact, which is needed, so needed right now. Third, we formulated our vision around the notion of conversations. Engage respectfully and openly, diverse voices in an inclusive way, in informed conversations. Good ethics starts with good facts. To address bioethical challenges in medicine, healthcare, science, and technology wisely and responsibly. Wisely and responsibly is key as we are facing some truly transformational changes, especially in AI, climate, aging societies, and some biotech innovations. Joshua, I'm looking at you. We emphasized conversations against the backdrop of an increasingly polarized world where misinformation and broken trust impede people's ability to have deep conversations and to listen to each other. We believe that we fill an important gap and can create opportunities for exchanges that sadly rarely happen elsewhere right now. Our research agenda will continue to tackle various topics, but will be strategically organized around cross-cutting themes that I will discuss today with my wonderful panelists. Our work will strive to promote justice and equity, remove systemic barriers to health and human flourishing, and reinstate trust and trustworthiness in medicine and science. And we're talking about trust as a time that science itself is under threat. Our publications are a powerful tool of dissemination and community building. We will invest further in making more content freely available to promote equitable access to knowledge. We will also make efforts to include diverse voices in our academic journals, the Hastings Center Report and Ethics in Human Research, and of course in our public-facing online publication, Hastings Bioethics Forum, that if you go to our website, you'll see has been publishing in recent weeks informed reactions to the changing landscape. As for our engagement activities, we plan to reach specific audiences in targeted ways. For example, policymakers, healthcare providers, journalists, Gina's here, legal experts, educators, advocates. We plan to leverage the multiplier effect by prioritizing expert groups that engage with their own audiences. So for the past over a year, for example, I've been having conversations with New York Times journalist Anna Sussman, that just in the last couple of weeks published a series of enormously big articles about the ethical issues surrounding human embryos. And I know that these articles have been read by millions of people. So the message of the Hastings Center reached those millions through the work of Anna in ways that we ourselves cannot. That is a part of our strategic thinking, the multiplier effect. We plan to enhance our engagement with our almost 300 Hastings Fellows. They are bioethics leaders who create a vast Hastings network. And we plan to secure and expand our pathway programs that provide educational opportunities to students and scholars aspiring to have an impactful career in bioethics. We just launched a new pilot program, the Stavros Niarchos Foundation Global Bioethics Program, that offers mentorship to international scholars from regions where they lack bioethics resources. The foundation is here, and we thank you for supporting this work. We also hope to reinforce our financial foundations to be sustainable long-term. In today's world, explaining this goal is not necessary. Financial stability will allow us to increase our impact and experiment with new, exciting research and engagement methods. We are grateful to our supporters over the years for allowing us to advance our mission. The plan is here, everywhere, for you to read, share with friends, tell us your thoughts, give us feedback. But before I move on to the panel, I do want, as promised, to say a few words about the current context. We can't talk about plans for the future without opening a conversation about the role of bioethics in today's world. A phrase that has long been a mantra of the Hastings Center is, I already said it, good ethics begins with good facts. If facts are in question, which they are today because of an assault on science, where does that leave ethics? Where does it leave the work we do to help guide practice and policy? Scientific and medical research are the building blocks of facts, of truth. Massive proposed cuts to the NIH and universities jeopardize the scientific process of building evidence. Without research, we don't have good facts. The harm of the financial cuts is compounded by the ideological dictates of what research cannot be done. Entire areas of research are being effectively silenced because they can't be funded or because existing data is being erased. Scientific publishing is also at risk. An additional threat is the one to the future of science and bioethics. These shifts send a message to the young generation of brilliant minds that it would be unwise for them to choose training and career paths in areas that cannot be sustained. All this is at the level of research. What about patients? What about communities here in the US and globally whose current and future care is impacted in tragic ways? What is the role of bioethics in this moment in time? I get emails from colleagues who say that our field is too silent. People even say that we're complicit because we don't speak up enough. Today Israel commemorates Holocaust Memorial Day. As an Israeli and a third generation, this is a difficult day for me emotionally. And we have with us here today David Goldman and others from FASB, an organization that takes young professionals to Auschwitz to open up questions about what makes regular people do bad things out of complicity. I was thinking this morning about Elie Wiesel's famous saying, the opposite of love is not hate, it's indifference. I was also thinking about Dr. King's the ultimate tragedy is not the oppression and cruelty by bad people, but the silence over that by the good people. I'm using the special meaning of today not to make inappropriate analogies, but rather to open up a conversation about what bioethics can and should do when science and healthcare are under threat. To help us think through these very complex issues, I invited two stellar speakers. Gina Kolata joined the New York Times in 1987 after working for Science magazine. She covers medicine and medical advances from the earliest stages, from basic research by laboratory scientists, we're in Rockefeller University, obviously, to clinical trials, to drug approvals, to the real-world experiences of patients. Gina is interested in conveying the excitement of discovery, but also in issues of equity and access to medical care and the ethical issues that are ever present in medicine. Gina, please. Sit in the middle. And Joshua Boger is the founder and former CEO of Vertex Pharmaceuticals, a NASDAQ 100 company with currently over 6,500 employees that he founded in 1989. He ran Vertex for almost 21 years and then chaired its Science and Technology Committee for another 8. Under his leadership, Vertex discovered breakthrough drugs for HIV treatment and for a cure of hepatitis C infection. Currently, the company's major products, the results of 25 years of effort, have shown the ability to mitigate the genetic defect of almost 90% of cystic fibrosis patients, dramatically increasing their expected lifespan. The latest product introduction from Vertex is a truly non-addictive oral pain drug that could displace opioids, a project started under Joshua's direction in the late 90s. Currently, he is the chair of the board of Alicus Pharmaceuticals, soon to submit a new drug application with the FDA for an oral drug that can arrest Stargardt's disease, a genetic disease that is the leading cause of blindness in children and young adults. Talk about someone who has impact. He chairs the board of Seromed, mid-stage clinical development company working to bring forward a potential breakthrough oral therapy for Lewy body dementia, a particularly severe Alzheimer's-like disease. And he is the lead director and longtime advisor of the UK-based Mom Incubators, a medical device company that developed the first truly portable baby incubator. Where's the baby? A device which has helped over 11,000 newborns since its European approval, including over 3,000 premature babies in Ukraine, with the US introduction planned for later this year. Joshua sent me a link to a TV interview of the developer who was building the incubator in, 2 minutes in front of the cameras. It was unbelievable. The impact of this technology is going to be far-reaching. Joshua has a PhD in organic chemistry from Harvard, and while at Wesleyan University, majored, as Joe said, in chemistry and philosophy. And in philosophy, he concentrated on Neoplatonism and the philosophical underpinnings of, surprise, surprise, ethics. He served on Hastings board for 9 years until 2014 and is now trustee emeritus and one of our greatest cheerleaders. Thank you, Joshua, for joining us. So, am I on? You heard me enough. I was just hoping to give you a flavor of the strategic priorities. And now I have a first easy question for Gina and Joshua. You know, we are known to be a nonpartisan center. And I'm asking you, what does it mean to be nonpartisan in the current political environment in which scientific research has become, in and of itself, a polarizing issue? Let's go with Gina.
Is this on? Yeah, it is. Okay. So as I explained to Vardit, I'm not an advocate. I'm a reporter, and we try to describe things and tell you stories that make people think about things. So for us to be nonpartisan means that, as people were saying in the discussion earlier today, we want to listen to people who don't necessarily have the same views as we do. We want to treat them with dignity and respect. Listen to what they have to say and not dismiss them out of hand. I'll give you an example. So I was talking to people about autism, and one researcher said to me, the people who say that vaccines are causing it they're not making it up. They're not just listening to Andrew Wakefield. What happens is, with a lot of these children, the time that their symptoms start to emerge is the same time they get the vaccine. So it's a natural thing to say, my child had this vaccine, and all of a sudden, my child started losing all of his milestones, regressing. The vaccine did it. If you listen to somebody like that, and you talk to them, and you listen to them with respect, instead of saying, that's ridiculous. Vaccines are proved and safe. That's going to turn everybody off, and no one's going to know where they're coming from. There's ways of talking to people and telling their story, and also telling what the science says, which is that in most of these cases, there's a genetic cause, and it's usually a de novo mutation, without making the person sound ridiculous. So that's the kind of thing we try to do by being nonpartisan. We try to find people who may not think like we do on hot-button issues and treat them with respect and ask them why do they think that? What's the reason? Listen to their story and really listen to their story and see why they said that. I did the same thing with trisomy 18 last year. We had a lot of stories saying it's uniformly fatal. Then I looked it up and I said, actually it's not. I wonder what happens if the families sometimes decide they want to have these babies, and why did they do it, and what is life like for them? And I found 2 families that wanted to talk to me, and one of them decided to have comfort care only, and the other decided to do everything that she could for that baby. And it was really interesting because we were in an era where everybody was acting like, trisomy 18, you need an abortion. And if you listen to people who have a different view, you can have a different view yourself of how people make their decisions and why and what it means for them and how they feel about it afterwards. What's their life like? So that's what nonpartisan means for a journalist. You're welcome.
Joshua, for a researcher and for pharma, what does it mean to be nonpartisan?
Well, I'm going to take a slightly different approach. I'm going to go back to the Greeks first before I get to pharma.
And your undergrad.
My undergraduate. So I want to resurrect a word. Apolitical and nonpartisan are not the same thing. If you go back to the Greek origin of the word politics, so politics was a word first used by Aristotle in his tome of Politica, and the word was a new word then, and the origin of the word is the Greek word polis, which means city. And so if you read Politica, and it's really a great read in English, I haven't read it in Greek. If you read it, it's not a theoretical book, and indeed Greek philosophy did not hold theory as the highest form of knowledge. Practical knowledge was the highest form of knowledge, and theory was actually a lower level of knowledge. So it's not about theoretical concepts. It's about how people and how and why people in a city should cooperate. Cities were relatively new then. They weren't brand new, but they're relatively new. And the most successful cities in the world were the cities in Greece that he knew about. And it was all about the common good. So for Aristotle, being political meant approaching every decision with the good of all the people in the city in mind and trying practically to come to solutions for problems that involved everyone. Now, later that term got its present meaning that most people have, which is more like partisan. And partisan actually doesn't come from the Greek. It's come from the Latin, partem, which means part. And so it really is a setting apart of yourself from parts of the community. So a partisan group defines itself in opposition to other people in the community. And indeed, the highest value of a partisan group is to win. And it's to win over the other group. That's fundamental to partisan groups, to partisans. So they're completely different concepts. And there actually is, by the original word origin, and I would argue the way we should talk about it, there's actually nothing partisan intrinsic in politics. Now, while I'm redefining words for you, I want to redefine another one for you, because partisans often call the other group morons. And I'm not going to revise moron for you, because moron is actually a slur. Moron was a neologism of the 20th century psychology, sort of the dark days of psychology, for people with who were adults who had a mental age of 8 to 12. And although one might believe in one's worst days that your other side of your argument is a moron, it's actually not true, so it becomes just an untruth about it. They're not morons, but they might be idiots. So the word that I want to revise the meaning of is idiot, and idiot actually comes from the Greek as well, and it comes from idio, which means one's own or private. So in Aristotle's time, an idiotes was someone who where everyone else was concerned with politics, pulled themselves out of the group and thought only about themselves. They were idiotes. Now, this meaning actually survived pretty well used until about the 14th or 15th century, and actually survives today in the phrase village idiot, who, by the way, isn't meant to be a moron. They're just someone who's unconcerned about the workings of the city. So I would tell you that it's okay to be political, but don't be an idiot.
So the scientist is doing the philosophical analysis. What am I supposed to do? The science? Thank you both. This is brilliant. Now I want to go a little more granular and ask you the following thing. More granular. Considering Hastings' strategic priorities for the coming years, and they are equity of access to care, trust in science, and I just presented them. Can you share some thoughts about the role that the pharmaceutical industry and the media should play now? And my first question is to advance equity of access to care. And this time, start with you.
Okay.
Do highlight some of your recent innovations.
I will, but I'm going to start at a high level again. I'm going to start with a principle at a societal level, because I think in a discussion of ethics, the whereas clauses are more important than what you're going to actually do. So what is the highest level principle of equity? And let's talk about some practical cases. Access to food, clothing, and shelter. I would argue, I would put forward for argument that it's a human right to have food, clothing, and shelter, and that human right isn't dependent on how hard you work or indeed whether you're a good person or a bad person. It is a human right because you're as a community responsibility. Now, it's not my responsibility to feed you, but it's our community's responsibility to feed you and clothe you and shelter you. And I don't know why it's not obvious that healthcare isn't a similar human right. Should be a shared community responsibility. Unfortunately, healthcare has an aspect of it that's quite different from food, clothing, and shelter that makes it more complicated. Because although there are improvements in food, clothing, and shelter, none of those are existential. There may be better houses, there may be more efficient food production, but it's existential that we continue to innovate in healthcare, and we saw that during COVID. So it is. You can't just say, let's distribute healthcare, and that's all I care about, because it's actually as existential that healthcare progress continues. And oh, by the way, for the last at least 3,000 years, healthcare has been the greatest driver of GDP of any other technology. So it will actually get you more food, clothing, and shelter more efficiently than any other driver. So it actually is synergistic with that. But we have a weird system in the United States. And by the way, no other country in the world that I know of has the United States system. So we have a weird system that worked okay for a while, and about this balance of innovation and delivery. When I started in the industry 47 years ago now, it was the entire pharmaceutical industry produced maybe 2 truly innovative drugs every decade. And our healthcare system has not only the drug itself, but the innovative drugs that come next, paid for by patients. That's the system. And when there are only 2 coming a decade, the innovation tax on the delivery of that actual medicine was relatively small. Now we actually have needed, fantastically celebrated breakthrough drugs every month. And that innovation and the innovation of the ones that'll come the year after and the year after that are paid for by patients. Now, there are more patients, but they're not exponentially more patients compared to the breakthroughs. So it's just math, people. The system doesn't work anymore because innovation, we're in the golden age of innovation. Now, I hear people say, we can't afford innovation anymore. Tell your grandchildren that you made that decision, okay? If you want to go back to the drugs of 1980, I actually looked up the list. Not a single drug on the top 20 drugs is in wide use today. Not because pharmaceutical companies have rammed it down your throat, it's because you don't want them. And most of the top 20 couldn't get approved today because they're unsafe in our definition of safe, and they're only marginally efficacious. So transport yourself to the next generation and tell the next generation they're going to have no progress. And that's an existential threat to our species. So we have to change the system. Now, I hear about drug prices a lot, but what I don't get is people complaining about prices. They should be complaining about costs. Prices are a number that actually no one pays. Cost are what the patient pays. And so I'd propose in my analysis of the problem, and I think this should be a pharmaceutical industry goal, is that the cost of every pharmaceutical should be zero. The prices are actually not high enough. So I'll say that again. The innovation needs to be paid for in a fair, fact-based way, but the cost of it shouldn't be borne by patients. It should be borne by all of us. So not because we're patients, but because we're members of the human race, and in our polis, if we pay for it in a political way. So to do that, by the way, you can't just tell the pharmaceutical industry to give them all away for free, because the whole system is built on the economics that has enormous number of cross subsidies in it. Almost nothing that you pay for in healthcare is paying for the thing you thought you were paying for. It's paying for something else. So we have to redesign the entire system, but let's not argue at the level of my plan versus your plan. Let's argue at the level of goal. What goal we want. I say the goal should be, and I think the pharmaceutical industry should get out front and say the goal should be for the cost of all pharmaceuticals to be zero. How do we make that happen? And innovation should continue.
Can we quote you?
Yes.
Gina, what does equity of access to care mean for a journalist, for the media?
Okay, so I'm back to my usual thing where I'm not an advocate, so I can only tell you that what I do is I tell stories, and I tell stories about issues with equity of access. So I've written stories for a story, at least one story, about people who could not afford the drugs that they needed, and some of them were going to GoFundMe to try to get their medications, or not refilling their prescriptions every month, trying to do all sorts of ways of trying to keep themselves going when their co-pays, these are people who often had insurance, but the co-pays were beyond what they could possibly pay for. And then there's another equity of access story that sort of is continuing, and that is we have miracle treatments for people with sickle cell, for example, and it's only one of the gene therapies. But very few, almost nobody is getting them, almost no one. Even though insurance will pay for it, the system can't handle many patients. And so there's only a few dozen maybe in the country that even have had it, when there's about 100,000 who could possibly benefit from this. And this is really difficult. Like, who are the lucky people? Why them? How did they get it? And it's like you dangle something in front of somebody and say, here's a cure, but it's not for you. Insurance will pay for it, but I'm sorry, it's not for you. There's no capacity here, or it's too much trouble, or you'll have to travel and you'll have to wait a month in a hospital while your family have to wait while you're in the hospital for a month. So we have some of these cures, some of these treatments are really miraculous, and yet in the stories that I've told, they're miraculous, but too many people are sort of on the outside looking and saying, I can't have it, even though it's there. I know it's there. And I would think that would be worse than not even having it at all, knowing it's there and it's not for you. So that's the kind of story that I tell, that sort of talks about this idea of equity of access to care. I don't have solutions. I wish that the cost to everybody was zero. And I do always ask about the cost of drugs. So, for example, I wrote last week about Lilly has a drug which does the same thing as something like Wegovy, the obesity drug, but you take it as a pill once a day. And this is fantastic when you think about it, because it doesn't have to be refrigerated. So you can ship it all over the world to countries that don't really have the the ability to keep an injectable drug refrigerated and distributed. You can make it in a factory. You don't have to make it in these special places. It could be a cheap drug. So I said, this is really great. Now you have something where you could have an obesity and diabetes drug that could help people throughout the world. What's the cost going to be? Well, they won't tell you. Their goal is to make it available to everybody who needs it. The question is, what does that even mean? I mean, I quoted them saying, we want to make it available. What does that even mean to make it available? One thing it might mean is that in the U.S., people pay a lot, and they make it available for a lot less money to other countries where people don't have much money, which maybe is a way of doing it. I'm not sure what the answer is, but as we just heard, the drug companies are going to finance their next drug on top of this one, so that I would wonder if Lilly is actually going to give it away at the price that would make it available to people in other countries that can't possibly afford these injectables that people are getting here. And even here, they can't afford it. So that's the kind of equity. This is the equity of access stories that, as a journalist, I would tell to make people think about it. I don't know what's going to happen, but at least you can raise the issue in a way that makes it sort of personal. People get it when you tell them a story. And if you just sort of say, oh, if you go on too high a level, they don't necessarily get it. But you tell them a story about people who can't get drugs who need it, and then it sinks in a little bit more. So that's my story.
Thank you, Gina. Listening to both of you, I'm realizing that this is the moment that bioethics is born in the following sense. If someone is sick and there's nothing we can do, it's a human tragedy, but it's not an ethical issue. As soon as the innovation is there and the drug is there and you tell them you cannot have access to it, that's where ethics is born, because then it becomes a societal issue and not just a tragedy, but rather
But it has to be taken on as a societal responsibility.
Not just our society, because we're talking about with this, like the Lilly drug, the whole world.
No, I understand.
Or with sickle cell too, the whole world. It's
Right.
not just us.
Right. So, yeah, as I was telling someone yesterday, we are an unusual species. We're not a special species. We're an unusual species. The entire human species went through a pinch point at some point in our history through an estimated 100 to 500 females. I say females because you can trace evolution most clearly through females through the mitochondrial DNA. So they're also more important. But it's 1 to 500 females. There's almost no species that we know on the planet who went through that kind of pinch point. If I ask you to find on the earth the most distantly related person that you can imagine, they are more closely related to you than 2 chimpanzees that live a mile apart. We are all the same person. We're all cousins. So we, as a species, we have a special responsibility to take that challenge, but not in a partisan way. We can't say the problem is you. That's a partisan answer to the problem. We have to say the problem is us. It's a political problem. And if you take it as a political problem, you can use ethics as your weapon.
Thank you. Let me take the conversation in a slightly different direction. I talked in my introductory comments about the current climate and the assault on science and on research that is undeniable. From a pharmaceutical perspective, from a media perspective, what can we do to protect biomedical research and science? And my built-in follow-up is, how do we protect the future of science and bioethics, considering students and junior scholars are questioning their ability to get training and to have future careers in the field? Who goes first?
I'll start. I think science hasn't had a good run lately, and some of it is deserved. Some of the bad run is deserved. when science gets, with its permission, in the middle of partisan debates, I think it damages science. That's not a criticism of the individual scientists, but when scientists during COVID were dragged into policy discussions that were controversial, the science came across to most people as arrogant, and then when the science changed, scientists lied to us. Now, you and I know that the scientific method, properly applied, changes the answer all the time. Not to everything. Earth is still round, for as far as I know. I have no evidence to the contrary. But for issues like how are we going to deal, how many feet apart should we be in COVID, the fact that the answers change is not a failure of science. It's a failure when the scientific conclusions with the data at the time are presented as policy. And so for scientists not to say, wait a minute, we're still studying that, instead of standing up with the policy person and saying the decision is this, that, and the other, and science supports me, let the policy people, especially the partisan policy folks, not the political folks. We have almost no politicians left. We have partisans. But there are a few politicians left. But when the partisans use science, science should object. And science didn't object in that. So we've got to do a better job at that. There is, and we've got to admit it, I'm here in a temple of academic science. There's papers published as recently as a year or so ago, but a really important paper published in Nature in 2016 from 1,500 scientists saying that 65% of them couldn't reproduce their own research. 65% couldn't reproduce their own research. And they couldn't reproduce the research of their colleagues 70% of the time. That's not good. That's not a good thing. That's not science being science. That's science rushing things into publication because of the rigors of the academic system. The academic system needs to take some responsibility for that. But the scientists need to realize that's bad science. And they need to realize that doing bad science that doesn't reproduce, is damaging science. And so there needs to be a bit more acceptance of the responsibility for that. Is there a similar irreproducibility for industrial science? Don't know, haven't studied it. I suspect not as high because there isn't a reward for it. There's no reward for it in industry. If you do an experiment in the lab in industry and they start a project on it and the project fails, you haven't gotten tenure. In fact, you'll probably be fired. So there's a counter mechanism that keeps that down. I don't think anybody who does irreproducible science is a bad person, but I think they're doing bad science. And so we need to do that. And that's hurting science a lot. So those are my two. I have some thoughts about longer term things, but I'll let Gina go.
Thank you.
Okay, well, since you mentioned the COVID thing, I do want to say that I think that one thing that maybe the media could have done a little bit more of is to give more voices to people who said that there was not a scientific basis for some of the recommendations. I did some of these stories. I did a study. There was a study, I think it was in the Netherlands, where they were asking about the spread. I think it was whether or not it made any difference if you just opened up the gyms. I mean, and we also had some, and it didn't. Nothing was spread more when people were exercising in a gym and here we had all the gyms closed. But then we also had some stories about other countries that had the schools open or states that had the schools open, but there wasn't that much of an emphasis on sort of other views. And obviously this was controversial, and there was a lot of recommendations, like in New Jersey where I live, the governor closed all the state parks. So like if you wanted to like walk on the C&O Canal, there's the DNR canal, I was thinking of the wrong canal. And there's like nobody there, but you couldn't go on there because there was a barrier. It was so weird. Like, why can't you walk on the canal all by yourself? But no, it was closed just because, who knows, maybe your COVID was spreading somewhere. So there was a lot of strange things, and there was not a lot of discussion in the media about, where are these things coming from, and why are the recommendations so different? And are we treating people with respect who have very different views when their science isn't so settled? So maybe there could have been more of that. I also think, though, that right now, when we talk about the systemic threat to science and biomedical research, what we're doing at the Times, and which I think a lot of other people are doing too, is we're trying to talk about what is being destroyed, what's being cut off. I wrote about the Diabetes Prevention Project and another project at Columbia as well that were just capriciously cut when they cut the funds to Columbia. And what did that mean? And why? And what was it about them that made them all of a sudden lose all their funding? And what does that mean to the science and to the scientists? I wrote about within the NIH what was happening when people couldn't go to meetings, couldn't publish their papers, couldn't get their lab supplies, couldn't do their research at all because of weird, unpredictable rules set out by DOGE. They were weird, crazy, and scientists were saying, we don't know. And then out of nowhere, like after 5 o'clock, usually on a Friday night, you'd get some sort of strange email that now you lost your job. So we were documenting that over and over again because if people don't know the kinds of threats, and I'm not sure everybody really what bothers me is I think maybe people don't care about scientists enough, but at least we're telling people what's happening to them. And when we talk about projects like the Diabetes Prevention Project, where they were going to do a study that was going to talk about diabetes and Alzheimer's disease. They were already halfway through it, and they were trying to figure out what are the risk factors. Are they actually getting Alzheimer's or a different kind of dementia? Is there any relationship between taking some of the drugs for diabetes? Does that protect them at all from getting dementia? They were like halfway through it. All of a sudden, study's over. So that kind of thing, maybe people don't care about scientists, but they might care about diabetes and dementia. So we're trying to sort of present these things. We're trying to do little vignettes of scientists who all of a sudden are being destroyed by the capricious acts of this current administration. But that's sort of the only way we can do it because we're not advocates.
Thank you both. I'm sure you have a lot more to say. I'm very eager to open the floor for Q&A. So I'll ask you to, in a very punchy, concise way, answer my last question. What role should bioethics play at this time? Very high level, and then I'm sure the conversation will continue based on the interests of our audience. Gina.
Yeah, okay, I just talked. Okay, what role should bioethics play? Bioethics is like sort of like our guiding light. It gives you it has principles. It has clear principles for how to think about things and how to analyze situations. So when you talk to a bioethicist, there is a way of reasoning through what's right and what's not right. So that's, to me, the high-level bioethics role. And that's how I've used bioethics.
Don't call us idiots.
No, I won't call you idiots. I actually agree with all of that, and I think a role here could be to exhibit and teach how to listen with rigor, and particularly to use my version of explaining the Hastings method to people, which is take an issue that can be partisan, survey the field, put people on a scale about where they are on the major issues, lop off the left-hand 5%, lop off the 5% at the right-hand side, and get the 90% in the same room. That was explained to me by Dan Callahan himself, and he said it's not because the extreme conclusion might not be correct, but they're too loud on either side, and they don't know how to listen. That's what they don't do. They don't listen very well. So get the 90% in the room to talk through the issues, not to come to a conclusion, but to listen to each other and to learn how to listen. So I think the role of bioethics is to both both practice and teach that, and potentially keep trying to make partisan discussions into political ones.
Thank you both, and the microphone is open. I'm sure at least something that was said here triggered some questions. Can people come up to the microphone, please? It's also streamed so the people online can hear. Thank you.
Hi, Alan Astro. One of the values that I know that Dan Callahan was very interested in was solidarity. And it does feel like one aspect of the current political moment is a sort of breakdown in social solidarity. And I think Dan would probably argue that the access to equity and trust in science solidarity is almost a precondition for both of those. So I'm wondering what your thoughts are about how we might promote solidarity, and whether just even as part of the mission of the Hastings Center, whether in any modest way it might be able to work to promote that kind of solidarity that would eventually lead toward support for activities like bioethics.
That was for me. I'm not a panelist. I think that is just right, and I think in a way that's what Joshua was talking about when he explained so beautifully to us what it means to be political and to feel that you're a part of a community and that you carry responsibility for your genetic cousins. And obviously, without that sense of responsibility for one another, it collapses into this individualistic view that, you know, we create those systems where we abandon some people and leave them outside, leave them behind. So I think obviously it's a beautiful term that actually has been less prevalent in US bioethics than it has been in European bioethics, which is it's recognized in most of the European literature as a key principle, if not the leading one for bioethical thinking. For us, it's personal autonomy. Very interesting cultural difference.
There's an example. I actually think the impetus for solidarity is just beneath the surface. And I know that from experiment. Thing I've seen a number of times outside a Walmart or a similar store. People coming out of the store, there'll be a table over there, there'll be a picture of a child who needs therapy that they can't afford. And people who went into the Walmart to save $3 will, and probably spent $4 more than they intended to spend, will put $10, and I've never heard, I actually stood next to one for an hour listening. No one asked anything about what the person did for a living, who they voted for, it's an inch deep below in at least the American psyche, I know. So I think we need to celebrate that, call for it, celebrate it, but also give people credit for the fact that they already believe it, but they've been conned into being partisans in a false narrative of scarcity. There's no scarcity. There's plenty of money. There's plenty of resources. We need to preserve our planet. We're running out of planet, but that's a separate issue. Running out of planet won't be solved by one group winning over the other group. So it's an inch deep, and we need to celebrate it and tell people they already believe it. They already believe it.
I love that. I think we're all touched by that, but your story is about individual giving, and we're talking about the systemic issues such as no universal health care, no maternity leave that is paid for by the state. We're abandoning people at the policy level, which is why our strategic plan is inviting bioethics to lean into those collective level issues, the systemic barriers. I believe, like you, that people are fundamentally good and that solidarity is baked into us, even genetically. But I think that the policy and the structural systems that we've created here pose enormous bioethical challenges that we hope to tackle straight on in the coming years. You wanted to?
I don't have anything to add.
We're inviting another question. Lorena just joined the Hastings Center.
So this is a little too tall for me. Take this down.
Great.
Okay. So Gina, you mentioned sickle cell and the treatments that are available and how they're inaccessible. That really spoke to me. I had sickle cell as a child. I received a bone marrow transplant, but part of that was we had to crowdfund to be able to even afford the transplant. So I wanted to pose the question, is what is the role of technology if it's inaccessible to a lot of individuals, or it's accessible only to very few individuals?
That's an impossible question. I don't even know how to answer it. I mean, it's kind of heartbreaking because you have people who spent decades working on this. Some of them at the NIH, spending a real, this technology didn't come out of nowhere. It came out of years and years and years of dedicated work. And finally, they find treatments that would actually change people's lives. And yet, the hospitalization costs are astronomical. And as Joshua was saying, they're funding the next generation of sickle cell treatments. On this one, the next generation, from what I've been seeing, is going to be incredible. You won't have to be in the hospital for a month. Everything's going to be amazing, but it's being funded by these $3 million gene therapies, which...
Because that's the way we designed the system.
Because that's how it was designed.
That's how the system is designed.
Right.
So
There's not
bioethics
answer
can
unless
point
we change the
out
system.
that the goals are not being met, and bioethics isn't going to come up with a health care plan for the United States, but it can help illuminate the practical, not impossible goals that should be the basis of a plan. And it is a classic Washington mistake, and it only comes from Washington. I've nailed this down. Is every time there's an issue, I can tell you how I've been down in Washington enough to know when a new issue comes up that needs legislation, you would think that people get in a room and analyze how to solve the problem. That is not how it's done. They reach into their drawer of legislation that didn't pass the last time, and they pull it out, and the other guy reaches in and pulls out the legislation, and they fight over that legislation that may have an effect on that problem. So there's very little problem analysis done in Washington because the process is partisan. We need to point out the defect in that for problem solving, but by starting from insisting upon certain goals as being the measure of whether either partisan plan is worth talking about. That's what's not done right now. If you started with the plan, with the principle that said that life-saving sickle cell therapy should be available to everyone who needs it, now tell me how you're going to do that. And I don't want to hear a plan that doesn't do that. That's not a legitimate answer to the question. We don't develop public policy that way. And bioethics can point out the failure there. It can't tell you the solution.
It's a very honest answer. Brad, you have a question? Can you make it to the microphone, or do you want to shout? People who have other questions, you can come to the microphone even ahead of time.
Thank you, all of you.
David, tell people who you are.
Oh, I'm David Hoffman. I'm a hospital lawyer, clinical ethicist, and I teach bioethics at Columbia. You may have heard of that school. Joshua, I've been sitting right there next to my friend Virginia, thinking about your analysis of cost versus price. And odd how the human brain works. It brought me back to the first time I met Dan Callahan, Joe and I did a continuing education program on stem cell research. This was 35 plus years ago. And we went out to dinner afterwards with Dan, which was fabulous. Thank you again for that, Joe. And Dan said, you know, we should stop talking about stem cell research. It's ridiculously expensive. It's going to happen in 5 years for 50 years. And he said we should be spending more of that money on vaccinations and wellness visits and all of the preventative care that HMOs were supposed to deliver. And I'm thinking in the context of, Vardit, your strategic plan for the Hastings Center, and I love adding bioethics to the name of the Hastings Center because nobody knows what Hastings is. I'm sitting here thinking about how we can achieve Dan Callahan's goal of prioritizing in the context of the role of government in making difficult decisions about allocation of resources. And I wonder if either of the two of you have a notion of what process is out there for reaching that elusive, nonpartisan consensus on method to do this more intelligently than allowing the price motivator to guide our scientific inquiry.
You're talking about prioritizing and allocating resources ethically and intentionally, not just in the delivery of care, but in the innovation pipeline?
Specifically in the innovation area, to Joshua's point about cost versus price. Yeah.
But are you also talking about should we be redirecting our resources towards preventive care like vaccines, and instead of directing them towards future care? Is that your question, or I'm
No.
confused on your
By
question?
what mechanism should we make those decisions other than letting the market dictate what will be a profitable drug based on price? For example.
I think that they make their decisions based solely on price because it seems like the price is always whatever the market will bear anyway. I mean, rare diseases get a high price, and common things like a pain pill get a high price. Everything gets a high price. Do you think they're making their decisions based on price?
I have a different answer. Pricing is a whole separate topic. Again, the price is something should be irrelevant to everyone, and the cost should be zero. So I've solved the problem. But I think your choice is false choice, because I don't think there's a resource constraint. I think it's a false choice. There's plenty of resources. There's plenty of money. We're just not allocating the money right. Now that I'm willing to have a discussion about, but it's not.
That was my question. How do we allocate whatever resources we decide to put into research?
But I would allocate the money to every possible, credible, scientifically vetted, but not consensus vetted, not NIH consensus vetted, every wacky idea by a smart person should get completely funded. There's plenty of money for that. Where am I get that money? I'll use the Willie Sutton rule. I'll go where the money is. There's plenty of money. We're not allocating resources correctly. There's plenty of money, but it's not about taking the money we're allocating to healthcare and redividing it. That's everyone who is hoarding their resources would love you to do that. That's a partisan's dream that you fight over the last little breadcrumb, okay? So it's just, that's a false choice.
But
We have plenty of money.
regardless of the resources, what mechanism, who, what panel, what board, what body should make those decisions?
I want to fund it all. I don't want an NIH process. I don't want a consensus process. That's where the market is superior to the NIH process. The collective wisdom about the future is almost always wrong. That's a scientific fact. So why would I use a group of people to decide what the future is going to be, since I can go back in history for at least the last 1,000 years and prove that that's incorrect? So I mean, think of the science fiction books that were written in 1960 about what we would be doing today and what we would not be doing. And they were whackily talking about cell phones that would fit in a car by now. So you don't know what the future is going to be. Don't make that a consensus. Somebody is going to have an idea that's going to radically change a disease that's important to you or your family that everybody else in the scientific community hates. But you know what? That person is pretty smart. We should fund them anyway.
So I just asked who we is.
Us, the collective us, we insist that taxes be collected until all of that is funded.
Thank you.
Virginia, you're coming to the microphone?
Hi there, Virginia Brown. I'm with the Hastings Center. It's a sort of couple-part question. I think the overall part of the conversation that struck me is about what can bioethicists deliver. I'm a bioethicist. I think that delivering product is really important. So, Vardit, I wanted to ask you to say a little something about Hastings on the Hill, right, as a kind of delivery mechanism, but ask our guests to say a little bit more about, you know, if you had that proverbial magic wand, what kind of product ought we be delivering? What kind of training to our science undergrads, our medical undergrads, our baccalaureate students? What kind of content to our journalists in their early training, I teach, do people need so that they can come to the spaces that you are in and think like this from the beginning? What might that look like? And I think Hastings on the Hill is a good example when we start talking about leaning into policy, and I think people should hear about that. Thank you. You're welcome.
So I mentioned in my introduction that a part of our thinking for the coming years is to identify specific groups of influencers, experts, and use what I call the multiplier effect. And of course, if you manage to inform policy and allow people to put aside their partisan view and think together about how to solve a problem in an informed, wise, responsible, political, community solidarity way, your impact can be enormous. And actually, it's what the Hastings Center has done when we issued famously and historically guidelines that ended up impacting the care of patients at the end of life in so many hospitals, or during COVID guidelines. We've done that multiple times. So what we did now when AI is starting to hit the ground, or is hitting the ground in so many healthcare systems and is implemented in a wacky way, in the sense that whatever works is just being sold and implemented, and there are no guidelines, accountability is unclear, nobody knows what the other is doing. How can we reach policymakers and regulators and help them think ethically about the implementation of AI? And the Greenwald Foundation was kind enough to give us a little bit of funding for a pilot project where we're developing a very simple, accessible tool that explains to policymakers what they should consider when they think about regulating AI in health. And then we created a group of reviewers, some of them policymakers and other experts, who look at the tool and give us feedback and tell us, is this useful? Will this be picked up? Will anybody even spend time looking at this? Will this get to the hill? Where on the hill and how? So then we're refining the tool and disseminating it. We're in the middle of the work. We don't know if this will work. It is a pilot. But the notion of bioethics working with policymakers to create tools for other policymakers is something that we're really excited about trying. Now, if this works for AI, it could work for many other things that are hot buttons, that are policy decisions that are on the table right now, federally, state level. But this is the kind of, thank you, Virginia, for the opportunity of a product, a deliverable that the bioethics community is eager to create, because we want to be relevant in all our fabulous publications and knowledge creation. we want it to have societal impact, and doing it through policy, through a journalist, is the best way of doing it. So thank you for that. And now your question was about education, and I think we're running out of time, and it would be a wonderful opportunity to talk about something that is so critical right now.
Well, I mean, I think you could, I think the Hastings Center, if it wanted to do even more, could push its methodology around ethical questions down to the high schools and down to the middle schools, and even down lower. Because
Where's the baby again?
Exactly, because to get to be able to approach issues that don't jump to my side's got 51% and so shut up. The partisan methodology is if you establish that methodology, that will stay with people. And that was going to be my suggestion about saving science as well. We need to teach science completely differently. We need to stop having science be about fact memorization and regurgitation in an age where on my phone I have more knowledge at my fingertips faster than anybody in history has had access to knowledge when they came out of their own head ever. So why are we still teaching as if regurgitating facts is hard? That's easy. So what do we need to do? What do we need to do in science? We need to insist upon science being taught by experiment. And I mean by real experiment, not by cookbooks that come out and that we know the answer in the end. I have blessed to have 3 grandchildren, so I've been watching children from 1 to 3, and I know even more so that every child's a scientist. Every child's a scientist. They don't form premature conclusions, and when they do, they get surprised and sometimes even laugh when they have a conclusion that turns out to be incorrect. So they enjoy being proved wrong. They push at it over and over again, and they never stop. And then somewhere in school, they stop doing that. And then science is not interesting anymore, and therefore, am I surprised that when they're adults, they don't mistrust science? Science was not the fun thing it was when they were 2. And it could be the fun thing again if we use the same method. For ethical issues, the Hastings listening methodology is just as powerful.
Thank you so much, Gina.
I have 6 grandkids, and I have to take issue with you because I really don't see that in the schools. In fact, there's one of my grandkids got really interested in medicine because when she was in 8th grade, they had this project. There was a girl named Mackenzie, and she had these symptoms, and the kids every week they would learn about like another symptom in her body, and they were trying to figure out what was wrong with her. They were being like the medical detectives. It actually was a real case. It was in New England Journal of Medicine. At the end, it turned out the girl had celiac disease. But we would discuss it at dinner. I didn't know either. I said, well, maybe it could be this, it could be this. But the kids, seriously, at least in the Princeton schools, they have a lot of interesting things, and I just don't see science there. Now, I don't know about the rest of the world, but where my grandkids go to school, they haven't had that experience. They're still really interested.
No, they
so
haven't
it's
had the
good.
experience because the curriculum doesn't do it correctly. And using CSI as a model for biology, where every complex medical disease is solved in 47 minutes, is but it's the same thing. It's as if it's a clue-based thing instead of an experiment. They're not doing experiments.
But it got her so interested.
They got her interested, but it's not what I'm talking about.
Okay, maybe it's
Right.
not. I'm just
And
saying that
physics
I see the kids still interested in science. Are they doing experiments? I don't know. Maybe not. Maybe not.
I don't think they understand science. Science can be taught this way. I know because the Museum of Science at Boston is the largest producer of curricula for physics in North America, and they take it all the way down to kindergarten, and you're doing experiments, and there isn't a section about here's what heat is and here's the Boyle's law, and it's all experiments, and it goes all the way through high school. So it can be done, it's work, it's a different way of doing things. When do they learn Boyle's Law? When they need Boyle's Law. They look it up on a computer and it's Boyle's Law and they know Boyle's Law, but they learn Boyle's Law when they need Boyle's Law to do an experiment.
But bioethics, how can bioethics come in? So we really thought, I guess for us, for most of us, like you guys are a resource where you can help. If there's always an issue, and you guys can help think it through and have a logical way of saying, here's what the issue actually is, because sometimes it can get lost. So that to me is where you help.
Yeah. Thank you.
Okay.
Your question will be last, but 3 grandchildren, 6 grandchildren. I have a grand dog, and I'm still waiting. But I have to share something that I promised Susan I'll share. This week, my son in biology class had an assignment in bioethics. He had to write about if he's watching now, he's hating me. He had to write an essay about prenatal screening, describe the available technologies. I didn't choose it. Seriously, it was his teacher that gave it to him.
It sounds staged.
And talk about the benefits and the ethical and societal issues. And he was Googling, and he sends me a screenshot where the first result on Google when he was looking for the ethical issues surrounding prenatal screening was the Hastings Center bioethics page, completely by chance. And so first of all, he wrote, "Way to go, Mom." I'm really impressed, because it was really a Google search on his computer, completely clean. And then after he read it, he said, this had everything I needed to start me thinking about the pros and cons and the societal level. So I think that our Hastings bioethics briefs are actually picked up by teachers, educators, by high school students, and they give a comprehensive view. They maybe not put all the people in the room, but they do give, the fact that he said this gave me everything I needed, the richness of the perspectives. I know, you guys started with your grandchildren, so I felt invited to throw in the story.
I thought you were going to say your dog is using it, but that's...
So I think that the Hastings Center has produced such materials that trigger, that promote critical thinking, that give the richness that you guys are talking about. It's not the scientific experiment, it's the conceptual experiment, and we're going to continue to do that.
Yes.
Last question.
Okay. Thank you so much for this conversation. Faith Fletcher, Baylor College of Medicine, and I work with Hastings on a number of things. But I'm interested, really, Gina, in your thoughts around in this moment where academics and staff and students are being silenced. How can we work effectively with media to get stories out, to really talk about things that are important in terms of patient care and health outcomes when it can be viewed as completely polarized in terms of the current administration? So are there things that we can do? I guess I see it as an opportunity to engage with media, but maybe not necessarily publicly put out our stories until it's an appropriate time, given some of the threats and challenges and concerns. And yeah, interested in your thoughts.
Interested in hearing your stories. We always are. And I also understand that sometimes people do not want to be identified with stories because of the attacks that could come. So when I wrote about the people at the NIH who couldn't do their work because of the crazy rules, we don't like anonymous sources. And you have to go through a lot of hoops to use anonymous sources, and that story had all anonymous sources. And sometimes we use a first name and a last initial. And sometimes people are willing to use their own names. But I understand the concerns, and I'm not sure how I would feel if I were somebody who wanted to publicize something in this environment when you have people who could go after you in a way that could make your life miserable. I mean, I don't know that there's an easy answer on that. There really isn't. And I sympathize, and I would never want to force that, even pretend to encourage somebody who's hesitant, really.
Okay, thank you. Thank you for your work.
I'd like to thank our wonderful panelists. I'd like to thank the Hastings Center team that put our strategic plan that has never been revealed until today on our website as I was speaking. Woohoo! So that it will be available a click away for those watching us online. The team that put together this beautiful event, I want to thank Rockefeller University for hosting us again. And all of you for coming to our party. A lot of work ahead for the media, for innovation, for bioethics, but we can do it together. And we're looking forward to your continued support and participation in our mission that I truly believe is more important than ever. Thank you, everybody.